Okay, and then I'll just do the Facebook bit. Okay, hi everybody. So I think we are now live on Facebook. Welcome. My name is Dr. Jo White. I'm a clinical psychologist and advanced certified schema therapist, and I'm absolutely delighted to be here with Rosie, who's going to discuss a phased orientated approach to schema therapy with us. So Rosie, would you like to introduce yourself and tell us a little bit about what you do?
Yes, thank you, Jo, first of all, for the invitation. It's very flattering to be in this group and on this platform. So thank you again. My name is Rosi and my last name is Reubsaet. That may be a bit difficult for non-Dutch speaking viewers, but that's how you pronounce it, Reubsaet. I'm also a clinical psychologist in the Netherlands. And I'm a supervisor schema therapy for the International Society, but also for the Dutch Schema Therapy Society. And over here in the Netherlands, we run our own schema therapy mental health care facility. We started with 5 colleagues a few years ago, and we do schema therapy all day, individual and in group. And besides that, we also teach about schema therapy, do a lot of supervision, travel around the world a bit to teach about schema therapy. So I'm having a great work-life balance.
Sounds wonderful, something that I would aspire to get set up in the UK. So, you know, maybe in the future.
Yeah, who knows?
So, yeah, maybe. So how did you come up with the phase-orientated approach, Rosie?
Yeah, that's a good question. I think it's something. It's always a nice story to tell. I think maybe now some 12 years ago we were recruited. My team was recruited as a new team to start with a day treatment for borderline personality patients using schema therapy to make them better. And this was shortly after the first research on schema therapy was published, and schema therapy was helpful and waiting lists were very long. So they thought, well, let's do some kind of a pressure cooker idea that people get therapy for 3 months and then 4 days per week. And then in that way they can recover quickly, and then we can really handle these waiting lists. So that was the start of my team, but we really didn't have a clue of what we were doing. We weren't trained yet. So starting from that, we just got better and better, and we learned a lot from Joan Forel and Ida Shaw. But we also found out that we wanted to have some more tools to guide the process, because as you all know, schema therapy is an intense process. It can take a long time before somebody progresses, or and also, how do you know when somebody's healthy adult is big enough to be able to deal with life? So when do you end? So that way we thought, well, let's make these therapy processes a bit more explicit, link them to child development, you know, because you want the client to develop through therapy like you want the child to develop through life. And that really helped us to make goals, define tasks, invent techniques to help patients go through these phases. So that's kind of how it developed.
I love that idea of you all being absolutely immersed in schema therapy, but also not having a clue what you're doing. And I've certainly been in that place, Rosie, where I've been, you know, after the assessment phase. I think it's really easy, isn't it, to get lost when it's such a long-term therapy, and there's so many different aspects of it that you're trying to think about and address. It can be really easy to get a bit lost or distracted by some of the coping modes, thinking somebody's a bit further ahead than they actually are.
Yeah, I totally relate to that. And I also think, in every course you learn about the first phase, the case conceptualization and your first imagery scripting, your first chair technique. But then what happens? And do you have to do this for the next 2 years, or do you have to do something else?
Yeah.
So it's very easy to get distracted. Yeah,
really. So you've got some slides to share with us, haven't you, about the approach?
Yeah.
So that'd be great to have a look at those.
I'll start sharing them. Let's see, here is the thing. Well, this is what I was just talking about. It's about developmental stages guiding limited reparenting. And this is a bit what I just talked about, the background of it. We found some difficult things in doing schema therapy, like getting distracted, losing the overview guidance. But also here in the Netherlands, there's quite some pressure to see a lot of patients every day. So it's really difficult to stay in contact, to stay attuned to every patient. So it's easy to lose contact or to lose depth in the process. And as always is in schema therapy with patients with personality disorders, you can't avoid getting mixed up in your own pitfalls. So you really have to be aware of that and have to try and figure things out, make a plan to cope with that. So that's what we thought. Well, we need a plan to be able to conquer these challenges. And the phase-oriented approach was our plan. And we try to adopt developmental stages, like in schema therapy. As a therapist, we have to be like a parent. And whether you are the parent of a baby or whether you are the parent of an adolescent, it really means something different of what you have to do as a parent. And the same goes for a therapist. When you are the therapist of a patient who just enters therapy, you do different things from a patient who is at the end of therapy. And when you try to focus on basic core needs that differ during this therapy process, then you can also adapt the interventions that you do according to the therapy phase you're in. When you think of parenting a baby, you do different things, and when you think of parenting an adolescent, and that goes the same for patients. So this is the idea. We kind of divided the therapy process in 4 phases. Here in the Netherlands, we follow the guidelines from research that it takes 2 years for a good schema therapy to work. So that's the time frame we took. And we divided that in 4 phases. The first phase, you can think of a baby or a toddler. We call it the start phase, and then really safety and connection. The first basic needs are the things that you focus on in therapy. You really want the patient to be in a safe therapeutic relationship. So that in the second phase, you can make some pressure, you can put some pressure on showing vulnerability in the therapy. And in that vulnerability, a patient can really work on his basic need for self-expression. He can express himself, he can talk about his pain, but also talk about the things that make him angry or that make him feel ashamed. So that in the third phase, when the patients kind of grew into adolescence, he can really juggle with this autonomy. What do I want to keep as my own? What is my identity? What do I like? What do I hate? What choice do I want to make? So that in the end, your own children. My oldest daughter now is 18 years. She's in this young adult phase. She is really doing her thing and making her own decisions, trying things out, really try and be as spontaneous and really experimenting with her life, the choices that she wants to make. And I'm really confident that she can make it because, you know, these earlier needs were met in her life. And that's what you want a patient to do also. You know, as a therapist, you really want to give confidence in that the patient has done enough schema corrective experiences, that the schemas are healthy enough, that this healthy adult is big enough to face life and its challenges.
I really liked how you spoke about pressure in the book, and a healthy pressure, because I think it's really tricky, isn't it, to often the pressure that we apply in schema therapy activates a lot of schemas and may often our clients want to avoid that, and so I liked how you spoke about that, and how the examples that you gave in the book around how to do that in a way that I guess using empathic confrontation a lot of the time, or directing people to engage in exercises maybe that they would avoid ordinarily to make themselves feel comfortable, but just how necessary it is for people to move forwards.
Yeah. I know what you mean, and thank you for the compliment. You know, and maybe that's also, I think you're also always, as a therapist, or as a parent, you are also the person you are. And I think I really believe that's also from the basic need of a realistic limit setting, that when development is difficult, you really have to push. Sometimes, you know, I do that with my children also. When I see them struggle with some developmental task, then I also try and see what can I do to make them move forward, to help them overcome this difficult thing. And that is, in my opinion, also what you have to do with the clients when he is struggling with something. You really have to, you know, rise the pressure and try to help him or her overcome this obstacle.
Yeah.
But it's difficult because, you know, from our own schema of self-sacrifice, we don't want to do anything rude, or we don't want to be a pain in the ass, so we just avoid that. But it's not always helpful.
If you've done a good job in the safety and connection, then there's that capacity in the relationship, isn't there, to provide that pressure. Yeah.
And it's also really rewarding when you find out that you've worked so hard on safety and connection, that you are able to give some pressure and be a bit more confronting. Then the relationship can handle that.
Yeah. Sense.
So this is limited reparenting in the different phases. In the first phase, it's really about safety and connection, and just as you do with small children, mostly you keep a slow pace. You focus on keeping the connection. You mirror a lot behavior, but also feelings, expressions. In the second phase, when it's more about this basic need of self-expression, then you really go into the schema therapy work, you know, trying to heal the schema. So you dive in deeper to really see the child and its unmet needs. And you really try to stimulate the authenticity with the client. And then it's helpful if you are also, you yourself as a therapist, are able to be as authentic as possible. I think that is one of the things that Jeffrey Young means when he talks about empathic confrontation, that you are as much yourself and authentic as possible, because that is, you know, also have to be connected with yourself to be able to do that. In the third phase, when it's about autonomy, you try and think about your teenagers. You have to provide some freedom for them to to try things out, find out their way, but you also are still responsible for the safety. So you also have to keep it safe and confront your children or your patient when they're too wild or doing things that are just destructive. And then in the end phase, it's about spontaneity and play, in the sense that you really want to stimulate patients to just try things out, find your own way, fall down in your pitfall, get up again, really learn to handle life in your way. And in therapy, you have to work on responsibility for your own choices. And also, you have to talk about what is realistic. And not there's no standard for healthy adults. Everybody's different. Everybody has other issues. Everybody has a different innate temperament. So you all have to take that into account to be able to have a feeling of what is realistic for a specific person. So one of the things I like from thinking about these developmental stages is that they also, that they go hand in hand with developmental task. Like children, they also, every developmental phase in childhood has a specific developmental task. Well, you can think about that in the same way for therapy processes. And it helps you to make these tasks and goals a bit more smart. And I think you all know this. SMART means specific, measurable, achievable, realistic, and timely. And you can really talk with your patient, do it together, and try and make these tasks and goals as smart as possible. It's helpful for you because then you as a therapist, you have some ideas. Okay, this is what I'm working on and I have this time for it. And in our experience, it's also helpful for the patients because they know what they have to do. They know what they have to deliver, but they also know what they don't have to deliver just yet because they're not up to it. So it really it gives some guidance in this long and intense process.
Helps you to really keep track of where they are in those phases as well, doesn't it? And actually, I think it's something that I certainly find I often don't spend enough time really drilling down and pinning down a SMART goal. Often they can be quite big, can't they? Which isn't helpful for anybody.
Yeah. Yeah, and it's I think for everybody it's more easy to just follow how you've always done things and just go on with it and go on with it and go on with it. But when you have the time to just take a breath, look together at okay, how are we doing? Where are we going? That's helpful, and also the thing that you're clear about your expectancies. That's also very empowering for the clients, because many of us also have demanding high demands, and from these high demands, you tend to put them on the patient also. And when you realize, okay, we're just in the first phase of therapy, that means that we only have to work on safety and connection. He doesn't have to do difficult things like changing his behavior. Then that's really also lowering the standards and making things more easy and relaxed, achievable.
Just like we do with our children, so be really clear about what it is that we expect at this point.
Exactly.
Yeah,
exactly.
And knowing that we don't expect the same from our 6-year-old as we do from our 10-year-old.
Yeah, that's the idea. Yeah, And this is the way you can think about that, like in the start phase. An important goal is that the patient allows his coping mode to be bypassed. He doesn't have to do it himself. If he could do it, well, he wouldn't be in therapy. So that would be a too high demand. But, you know, he has to allow you as a therapist or the group, when you're in group therapy, that his vulnerability is open and that the coping mode is aside. It has to happen, I don't know, maybe 2 or 3 times. You can think about what is achievable in your situation. And the task that accompanies that goal is that the patient has to be aware of the pros and cons of this coping mode. So you do some exercises, like some chair exercises, talking about these pros and cons, for example. In the second phase, you can, it's clear that the patient can bypass his coping modes, but he has to learn to do it for himself. You know, so he has to practice, that's a task, to kind of confront his own coping modes. So that it's not that, so that the patient is no longer dependent on the therapist or the group to do it, but he can recognize it himself and also say to himself, oh, wait, I'm not going to surrender this time. It's not good for me. I have to try and do something else.
And I guess while people are doing that, I imagine that people might be quite explicit that that's what I'm doing. I'm noticing that my angry protector is coming up, but I'm trying really hard not to let that mode take over.
Exactly. Yeah. So in the third phase, it's an important goal that they, and I think this is a bit how we live, is that when you see yourself being this angry protector, it's a signal. It shows that something vulnerable has been touched, or that some need is not being met. And then you want the patient to have a mild attitude toward this coping mode. You know, I think many patients are very harsh. Oh, I should know better by now, and here I go again, being angry and just pushing everybody away. I shouldn't do that. Well, that's not so helpful, because this coping mode also used to have a function. So it's and maybe in the end, you want to keep some of this energy that is connected to this angry protector, for example. So you really want to practice a mild instead of a harsh attitude towards yourself when you're finding yourself stuck again in your coping mode.
So you mean using humor, or just a kind of lightness?
Yeah, exactly.
Here I go again.
Exactly, and also really training and shaping them, modeling in how the tone of voice you use when you want to say something in a mild way instead of in a harsh way, the way you look when you want to also transfer some empathy. You know, a lot of our clients have no idea. You know, we teach our children this, but our clients were never taught these small signals. So you can also train these things. Just practice and look and talk. And how does it feel when you say it this way? How does it feel when you say it that way? Yeah. And the book is full of this kind of examples. And in the end phase, it's like, it's even more like I live my life, you know, dealing with the difficult feelings. So every now and then, just going along. And the only thing you can do is that you can switch to your healthy adult mode. And that's an important thing to practice in this end phase. You can't prevent going to your pitfall, you can't prevent ending up in your coping modes, but you can switch to your healthy adult mode. And the sooner you do that, or when you're able to ask for help to do that, then you don't have to get stuck in it. You can have a nicer life.
So perhaps this is a good time to talk a bit about your book, Rosie. I think we were going to talk about a client, weren't we? But I think we've run out of time to do that.
Yeah, out of time. Yeah.
We've done well talking this through. So yeah, would you like to say a little bit about your book? So the phase-orientated approach is detailed in your book. I've got my copy right here.
I've got mine here too.
Do you want to say a little bit about it?
Yeah, well, I read for the first thing, I really liked writing it, so that was a major task for me. So that was the biggest thing. And what is really nice is that I hear from a lot of people that they like the structure that is in it, and that they like, on the one hand, the theoretical framework in talking about these phases, also group developmental phases, and also the amount of experiential exercises, which also makes it a very practical and easy to use book. So those are very big compliments for me.
Yeah, it's absolutely rammed full of experiential exercises, isn't it?
Yeah.
There's some nice ideas that I'm going to be using this week, actually.
I counted them, they're over 30. So
really?
That's quite a lot.
Yeah, quite a lot, yeah. Oh, thank you so much, Rosie, for taking the time to come and share with us your approach. It's such a helpful way of structuring long-term work, isn't it? When often I think we can find ourselves getting a bit lost and uncertain about what we should be focusing on. Yeah. So I think it's going to be really useful for lots and lots of people. So thank you so much for taking some time to talk to us.
Yeah, you're welcome.
We get to meet up again soon.
Yeah,
okay.
Great.